Hi, everyone. Thank you so much for joining us today. It is 1 p.m., so we will go ahead and get started. My name is Nicole Jerome, and I am a consultant with JSI. JSI is a public health research and consulting organization based in Berkeley, California. And we've been working in and with the state in various different capacities for over a decade, and we are looking forward to sharing with you today some of the work that we have been most recently working on, specifically to understand how Medi-Cal managed care plans are approaching social determinants of health. I wanted to take a moment to thank the leadership team at the California Association of Health Plans for the opportunity to present to you all today. And I also wanted to note that this work was made possible with the financial support of Blue Shield of California Foundation, as well as the California Healthcare Foundation. So before we begin, I'd like to go over a few housekeeping notes. First, this session is being recorded and will be made available to those who are interested. But on that note, please stay on mute throughout the duration of this presentation. You have all been muted upon entering this session, but you do retain the ability to unmute yourself as needed, which will come in handy at the end of the presentation when I open the floor up for questions. However, until then, please make sure that you are on mute. Lastly, please hold your questions until the end of the presentation. I will queue for questions specifically. There is a lot of material that we are excited to share with you today, and so I'm sure there will be a lot of questions. So for efficiency, we'll just hold until the very end, and we'll have a question and answer session. Thank you for understanding. Thank you for joining, and with that, we will get started. So over the next hour together, I will provide you with a quick synopsis of our research overall, but to get us started, I will first cover our research methodology. Then I will go into discussing some of the findings about what's currently going on among California Medi-Cal managed care plans within the landscape of managed care in California, in terms specifically around social determinants of health, as well as what challenges are bubbling up for plans who are making investments that focus on social determinants. I will also highlight some key opportunities for the future that we identified as a result of our work. And finally, I will walk you through the findings around a specific opportunity, a rate adjustment approach, which is an opportunity that emerged as we were doing this work. After all is said and done, like I mentioned, I will open the floor up for questions. So before diving into the content, I will briefly describe our process. The purpose of this work was to learn how California Medi-Cal health plans are thinking about and approaching social determinants of health. Specifically, we wanted to know more about how they are responding to social determinants at the member level, as well as at the community level. We also wanted to explore what factors encourage plans to make these type of investments and what factors make these investments a challenge. In order to answer these questions, we created a survey that was administered to both local and commercial health plans in the summer of 2018. And after that survey, we conducted follow-up interviews with health plan leaders to further explore survey results. Of the 23 eligible Medi-Cal managed care plans that we invited to participate in our survey, 19 responded to the survey for a completion rate of about 83%. Among survey respondents, we were able to contact and speak with 14 plans for follow-up interviews. Accordingly, the data that I am about to share with you captures both local and commercial plan responses, although it is important to keep in mind that by sheer numbers alone, as you can see on the slide in front of you, local plans provided a bulk of the responses. So what did we find out? We have organized our main takeaways into 6 key findings that you see on the slide in front of you. I will go over each one of these briefly today, but I do want to make a note that a detailed report summarizing all of this work will be available to you shortly. So if you don't catch everything today, in addition to the recording, that report will be coming out. But let's get started on going through each of these 6 key findings around the current investment landscape in California. So the first finding that I will cover today is that most investments that Medi-Cal managed care plans have recently or are currently making focus on identifying and addressing individual social needs. What do I mean by individual social needs? Well, there are many different strategies to respond to social determinants of health, and they can be considered as spanning across a continuum, similar to the one that you see on your screen. Some of these strategies focus on the individual, while others go beyond addressing the needs of a single person and try to improve conditions within a community overall. Strategies that focus on individuals tend to create isolated short-term impacts, but can lead to meaningful improvements in the day-to-day life of an individual. For example, providing food vouchers to a patient who presents with food insecurity would give them access to food for a couple of days, but a community-level strategy is more likely, maybe more likely to address the root causes of where that food insecurity is coming from, and therefore more likely to create longer-term impacts for community members and a community overall. Strategies don't necessarily fit into the perfect boxes like you see on the screen, on your screens, but based on our work throughout the years, we've found that strategies do tend to fall along this continuum. When we took a look at the investments that plans described making, we found that plans are investing in and using strategies that focus on addressing the social needs of their individual members. So they tend to fall on the left-hand side or the individual side of the continuum illustration on your screen. So when we asked plans specifically what they were doing, we found that plans are implementing pretty similar strategies to address their individual members' social needs. Almost all plans reported that they were using a referral system to connect patients to external resources and social services and investing in community organizations that focus on addressing the social needs of their members. As you can see on the graph in front of you, 95% of plans reported either investing in a referral system or investing in community organizations to address the needs of their members. As you can also see on this slide, nearly 80% of plans also reported investing in screening to identify their members' social needs and also hired community health workers and or patient navigators to help address those needs. So our survey gave us a broad snapshot of what has been going on in the Medi-Cal managed care landscape recently. And through our interviews, we were able to dig deeper into our survey data and understand what these strategies look like in practice. So as I noted on the previous slide, nearly 80% of plans reported screening their members for social needs, while 95% of them reported implementing a referral system to connect members to external resources that could address those needs. One example of these 2 strategies at play is Kaiser's Your Current Life Situation tool. Kaiser plan leaders we spoke to described creating a new screening tool entitled Your Current Life Situation, or YCLS, and designed it to identify a range of social needs such as housing, childcare, and transportation. Originally designed to assess the needs of members who are at risk of high care utilization, this tool is increasingly being deployed as part of the onboarding process for Kaiser Medi-Cal members. Kaiser is also investing in building out an enterprise-wide service locator that staff can use to connect members who screen positive for the social needs that they identify and connect them with local services. For the most part, plan leaders didn't describe their screening or referral efforts in much detail during our conversations. However, some leaders did mention several other tools that their plans are using to screen for social needs specifically, including the Staying Healthy Assessment, Bright Futures, and the Prepare tool. Another example of a strategy to address social needs in practice is hiring community health workers or navigators. And as I mentioned, 80% of plans reported creating or hiring staff in order to address social needs. When we spoke to plan leaders, they told us that they have hired community health workers, social workers, care coordinators that focus on homeless members specifically, and even administrative staff responsible for leading efforts around community-level engagement with a specific eye to health equity. One salient example of this type of work is Inland Empire's community health worker model. Inland Empire is working on building a workforce that goes upstream by adding the community health worker role, especially the role of promotoras, into its care team model. This care team will include a community health worker along with a behavioral health clinician, a nurse, and a case manager. Integrating the community health worker will enable the care team and plan to collaborate better with local organizations and connect priority populations such as pregnant moms and kids to available services. The second finding I will describe today is that while plans are focusing on addressing individual members' social needs, they are also making community-level investments. When we asked plans to tell us whether or not they were investing at the community level, 2/3 of plans reported that they were making investments that respond to community needs, such as social conditions, or just going beyond their members to provide services or resources at the community. Community-level investments are specifically open to the entire community, so they don't include services for just members, but can include resources for anyone who lives in the vicinity of a plan or the area that a plan's investment is taking place. On the right side of your screen, you can see a couple examples that plans gave us as community-level investments. And I want to zero in on that $5 million plus community resource investment. This was an example from Inland Empire, who spoke to us about making an investment in 3 community resource centers where both their members and non-members can access a variety of services. For example, tax preparation workshops, nutrition classes, fitness classes, and prenatal workshops. All things that definitely can help people lead healthier lives, but are not necessarily constrained to the healthcare sector. We also found that while plans are responding to many different needs that are issues that arise from various different social determinants, they are prioritizing certain social determinants in their investments. The 3 determinants that, or the 3 categories that most plan investments dealt with addressing were housing instability, lack of transportation, and food insecurity. I want to just make a quick note about the time horizon of this data. So when we this comes from our survey, when we asked plans to reflect on their investments, we asked them to reflect on the year prior to when we administered the survey. So the data on this slide most likely, or represents investments made between September 2017 and September 2018, give or take. So pretty recent investments, but just wanted to make a note on that time consideration. So what is an example of a recent investment to address housing instability? As I mentioned, most plans are investing housing instability. And when we spoke to plan leaders, they told us that largely their plans were making grants toward building housing, including supportive housing, and expanding respite care capacity within their communities. For example, in 2017, LA Care made a $20 million commitment to addressing the needs of LA Care's the LA area's homeless population. This grant is being distributed over 5 years to Brilliant Corners, a local nonprofit supportive housing agency. And this investment is also expanding the reach of LA County's Whole Person Care Initiative by allowing the county to redirect some of its general funds to the social service needs of the homeless population in the area. Many plan leaders also described using grant programs to make investments in food insecurity within their areas. For example, Central California Alliance for Health shared that over half of their members experienced food insecurity during a survey that was administered in 2016. So to address this need, the plan created the Partners for Healthy Food Access Program, committing a total of $4 million that will be awarded in the form of grants of up to $200,000 each to local partners addressing food insecurity. This program supports innovative partnerships between healthcare providers, community-based organizations, and government agencies to decrease food insecurity through different strategies, such as screening, on-site and easily accessible food distribution, as well as connection to more long-term food services, such as CalFresh. And as a very quick note, I do not include a transportation example in this presentation, mostly because when we asked plan leaders to tell us what kind of transportation investments they were making, it became clear that now that transportation is a Medi-Cal benefit, plans are largely relying on Medi-Cal dollars to provide that benefit. So when we asked plan leaders to tell us about their most significant investments, transportation did not come up since it is now considered a Medi-Cal benefit. However, I will say that a few leaders did mention partnering with Lyft and other organizations outside of healthcare to deliver this new benefit. And one plan even told us that they have expanded their transportation benefits to allow members to travel to and from housing-related services. They found that while they were working to connect members with housing, once they could connect members to potential housing opportunity, members couldn't actually get there. So they have expanded their benefit to include this. Our fourth finding is that plans are prioritizing addressing the needs of their high-utilizing member populations with their investments. In our survey, we asked plans to estimate how many members their investments were reaching, and 55% of the investments that plans indicated making reached 5% or less of their membership. As you'll note on this slide, most of the dots here, which represent different estimates of the reach of investments, tend to hover on to the left-hand side, while only 10% of investments reached half of plan membership or more. When we spoke to plan leaders about this, the leaders were able to confirm that most of their investments that they are making do tend to prioritize the needs of high-utilizing members because they are the members that drive short-term costs and can significantly impact in the short term where there needs to be addressed. So how are plans funding these investments? Well, investments are largely dependent on reserve funding, as you can see on this slide. Leaders from the 14 plans that we interviewed told us that they are currently not receiving any credit for most of their investments. So accordingly, they were mainly tapping into their reserves to make these investments happen. That said, in our survey, approximately half of all plans also reported using in lieu of or value-added services as a strategy to help finance their social determinants work. In lieu of services are cost-effective alternatives to services or settings that are covered in the state plan and that plans may choose to offer their members. The costs of offering these in lieu of services can be included in both the medical loss ratio as well as the future rates, so they can be very helpful mechanisms to use to provide care for members. An example of employing this that some of our interviews brought up is that plans described some efforts to transition members out of institutional care and back into their homes or community-based settings. Value-added services are services that managed care plans can choose to provide members but are not included in the state's plan. Therefore, the cost of these services can be counted in the medical loss ratio, just like in lieu of services, but not in future rates. So far, these additional services have largely been approved for the dually eligible population, and in conversations with plan leaders, they talked about a desire to negotiate for the inclusion of more of these types of services for all of their members when setting rates. Our survey also found that 42% of plans reported using quality improvement activities as a strategy to financially support this work. And while no plan leaders did not go into detail around what strategies they were specifically classifying as quality improvement activities, screening is often considered a quality improvement activities by plans, and so that's just of note. Additionally, several plan leaders also described incorporating investments, especially those that focused on strengthening their own workforce, into their administrative or care coordination budgets, for example, as part of their case management component. And finally, although not a direct financing strategy, some plan leaders did discuss leveraging Medicaid demonstration projects wherever possible, simply to maximize the impact of the investment that they were making. For example, one plan explained that since the Whole Person Care Initiative in their county is focusing on homelessness, this plan made an investment to expand the capacity of local respite centers, which Whole Person Care is then providing the per bed, per night funding for on an ongoing basis. This housing-specific investment, it maximizes both the reach and impact of the investment itself and the Whole Person Care program in the county. So we noticed that come up in a couple of our conversations. The last overall finding about what's currently going on in terms of investments that I will talk about is about what is driving the decision-making process behind making these investments. So when we asked plan leaders why they were making investments and what went on behind plans in terms of making decisions to go forward with this type of initiative and effort, three main reasons rose to the top. First, mission to serve community. As you can see on this slide, 79% of plans rated missions or values of their organizations as the top factor influencing decisions around how to spend their reserves. In interviews, plan leaders spoke of their members' health as inextricably linked to their social needs and confirmed that plan missions play a big role in influencing investments not only for their members, but for the broader community when those are being made. Plans also reflected that responding to social determinants is essential to improving quality outcomes and serving their members well. Accordingly, as you can see on the slide, 63% of surveyed plans identified quality considerations as an important factor influencing investment decisions. Additionally, over half of all plans identified that they are driven to invest in social determinants because of community needs and needs that, in general, that they have identified, either formally through assessments or informally. An example of an informal assessment is that some plan leaders told us that the housing crisis is very visible in their communities, thereby prompting plan leaders to try to address it through their plan's efforts. One of my favorite quotes from this work is the quote you see on your screens now. Our philosophy is that health is no longer just the doctor. This really drove home how important and embedded plan missions are in the decision-making process around how to approach social determinants of health. And the last key feature driving investments that we identified as part of our conversations with plan leaders is that right now plans have a unique financial opportunity to make these kinds of investments. Medi-Cal expansion has led to a period of relative financial health for many plans in which the size of their reserves has grown over historical levels as a result of Medicaid expansion. I will note that not all plans experience this expansion or the increase in reserves as a result of expansion. However, time and time again, we heard that from plan leaders that right now there is a good opportunity to make some significant focused investments as a result of the size of their reserves. However, I will go over this shortly. The fact that most investments are not currently reimbursable is a huge challenge to making them, but because of the period in time that we are in right now, plans are financially flexible enough to be able to cover some of their members' needs that don't fall into their managed care contracts. So while plans named many different reasons for making the investments that they did, these three overall factors, mission, quality considerations, and financial opportunity, rose to the top throughout most of our conversations with plan leaders, and so we've chosen to highlight them here for you today. So now we'll transition to some of the challenges that plans are facing. I'm sure that for those of you on the call, some of these challenges will be very familiar to you, and we really wanted to highlight the voice of plan leaders in this section especially. So I will walk you through 4 key challenges that emerge throughout our conversations with plan leaders. So like I just mentioned, plans are currently experiencing a period of strong financial performance following Medicaid expansion in the state, but plan leadership is also very cognizant that this period will likely not last. Perhaps one of the biggest challenges that plans are currently facing is a lack of consistent, sustainable funding for these types of investments. Consequently, plans are very cautious about the amount, quantity, and size of the investments that they are making out of their reserves. Leaders from smaller plans noted that the expansion of Medi-Cal did not result in large reserves for them, which only limited their capacity to make and sustain investments that may benefit members, but are not reimbursable in the current rate-setting process. Additionally, while plans acknowledge that they do have a role to play in helping to meet the social needs of their individual members, there is uncertainty around what roles healthcare entities should play and where responsibility for social determinants should fall when it comes to plans, county health agencies, public agencies in general, and community-based organizations. Specifically, some plans told us that they limited some of the investments that they could make because they were concerned that their actions would only duplicate community efforts that were already underway to address social needs. A third challenge that plans reported is a lack of conclusive evidence describing what strategies can actually work to respond to social determinants. While the evidence base around these kinds of investments is growing, there is still a lot of gaps in the research, and plans are consequently struggling to determine how to best use their limited resources for their members and communities. And finally, the fourth challenge that I'll cover today is that partnerships are difficult to establish. However, these partnerships are critical to investments, especially at the community level. And many plans did tell us wanting to be able to better collaborate with community partners to be able to better meet their members' needs as well as their community's needs. However, they described a couple of roadblocks to establishing partnerships in the ways that they would like to. First, while plans currently have funds available to establish partnerships or may have funds to establish partnerships, some leaders describe that they have had challenges finding community organizations with the interest, bandwidth, or required resources to find partners or resources to partner with plans. For example, some plans have found that community organizations don't always have the staff time required to implement a plan-funded initiative. Second, systems that would enable secure information exchange are currently not as available. Without the proper systems in place to securely measure and share impacts across organizations, scaling scaling investments at the community levels that focus on addressing social conditions become very challenging to sustain and very challenging to show the impact of. So While these 4 challenges are by no means the only challenges that plans are experiencing when making these types of investments, they are ones that came up pretty frequently in our conversations with plan leaders. So I will leave this slide up just for a minute so we can all take it in, and then I will move on to describing some opportunities that exist for plans and and the state at large. So, like I mentioned, there are many challenges that plans are experiencing, but there are also several common opportunities that exist to help sustain these types of investments. In the next few minutes, I will go over some of the insights that emerged, some of the opportunities that emerged as a result of the research that we did for this specific work and our experience in the field. So, based on what we've learned with our conversations with plan leaders, we've identified several opportunities. The first of which is to define expectations for a rate adjustment proposal in a shared policy platform. These opportunities are specifically for Medi-Cal plans, and this opportunity came out of a number of things, but what we found in our survey is that when we asked plans to tell us what state-level policy changes would encourage or help them sustain their investments in social determinants, most plans, about 70%, prioritized a rate adjustment approach. There is undeniable strength in numbers, though, and coming to a consensus around what a rate adjustment approach might look like could help advance a proposal at the state level were plans to have an interest in moving something like this forward. I will actually go through this opportunity in detail in just a few moments, so we will be returning to this. Before I talk more about a rate adjustment specifically, I'll go through the other opportunities for plans. The second opportunity that we identified is to evaluate promising practices. Plan leaders told us that there is a need for more systematic evaluation of initiatives related to social determinants. At the same time, however, plan leaders told us that their individual plans are already identifying ways to evaluate their own investments. As these evaluations are conducted, plans have the opportunity to share emerging information with one another and disseminate findings around what they've already found to be effective. And this information can be disseminated through a variety of ways, including plan association convenings, either virtual ones like the one that we are currently in today, or through dissemination platforms that already exist to spread information. One example of a dissemination platform already out there specifically for social determinants of health work is the Siren Initiative, which is based out of the University of California, San Francisco. The third opportunity is to leverage the leadership roles that plans often have in their own communities as a way to foster partnerships. Plan leaders repeatedly told us that partnerships are very important to effectively addressing social conditions in the community. And plans have a high profile as authoritative voices on health issues, as well as large employers and purchasers within their communities. Consequently, plans have the opportunity to lead and serve as conveners in their communities, encouraging other partners to come to the table and work on social determinants. Finally, develop a community of practice. Plans are responding to social determinants in many different ways. It's important to document learnings, identify common barriers, and generate policy change ideas through both formal and informal venues as ways to propel this type of work and the field overall forward. It also became evident that there are many different opportunities for the state to consider. I won't go through each of these opportunities in as much detail given time constraints, but the opportunities that we identified for the state are: one, to implement a rate adjustment, similar to the opportunity that we identified for plans; two, expand plan authority to pay for supplemental activities; 3, incentivize or require investment. 4, incorporate best practices from housing-related pilots into managed care contracts. And 5, clarify expectations and allowed areas for flexibility and innovation. Most of these opportunities are around funding mechanisms, mainly because of the state's role as a regulator and funder of the Medi-Cal program. While I'm not going through these in detail today, more very specific details around each of these opportunities will be available in our upcoming report. I would like to point out that the first state opportunity here is to implement a rate adjustment. One of the central challenges that plans shared is that they are not receiving any credit for the investments that they are currently making. A rate adjustment could help lessen these financial-related challenges that plans are experiencing, and is something that both plans and the state may want to consider. So I will spend the next few minutes going into a little bit more detail into this opportunity specifically. As part of our conversations with plan leaders, we asked them what they thought about a specific rate adjustment approach. So I will go through some of the findings around those series of questions. And as a reminder, opportunities for questions will come at the end of the presentation, which is not too far away. So please hold questions until then when I ask for you to unmute or use the chat box, but more to come on that in a bit. So in 2018, the California Healthcare Foundation released a report that outlined a rate adjustment strategy designed to specifically incentivize health-related investments that can improve member health, but tend to fall or do fall outside of traditional Medicaid benefits. An example of these types of investments or health-related investments are investments to respond in social needs. The image you see on the slide in front of you is the cover of that report. And so, as I mentioned earlier, our survey found that plans prioritize a rate adjustment approach as a potential state-level policy change that may encourage additional investments or sustain investments in social determinants. So, with support from the California Healthcare Foundation, we used our follow-up interviews with plan leaders to further gauge interest among plans and get input on specific elements of the proposal of the rate adjustment as proposed in the report. Before I go into details, though, let me go through how this proposed rate adjustment would work in the first place. As outlined in this report released by California Healthcare Foundation, a rate adjustment would allow plans and the state to share savings that are generated as a result of effective investments in health-related initiatives, thereby mitigating some of the risks that plans bear alone because of these investments. So to trigger a rate adjustment, plans would need to meet 3 triggers. First, they would need to meet quality targets. Second, a plan would have to generate savings above a minimum threshold. And third, a plan would have to invest a minimum amount into state-approved health-related initiatives. We asked plan leaders about their thoughts on the overall approach, and we also focused on the second 2 triggers, the minimum threshold trigger and the minimum amount, the savings above a minimum threshold trigger and the minimum amount into approved health-related initiatives trigger. So I'll go through some of the findings that came out of the series of questions we asked around this proposal. So overall, plan leaders confirmed support of this approach. They told us that even if they weren't entirely familiar with the report itself, they understood its importance as a potential way to sustain investments that respond to social needs, thereby confirming what our survey had told us earlier last year. We also learned that upfront risk sharing is as important as back-end shared savings. As I described, a rate adjustment would allow plans and the state to split any savings generated as a result of health-related investments that plan made. That is, the savings generated would be split on the back end. But plan leaders made it clear that it's still important for the state to acknowledge the risks that plans take up front, especially since some of the impacts of the investments that they are making don't necessarily materialize during the short time horizon used during rate setting. Third, plan leaders told us that they are largely not receiving any credit in the rate setting process for these types of investments, so it's really important that they receive some credit. When we asked them whether or not they would prefer credit in the medical load, in the non-medical load, or neither, plans, for the most part, emphasize receiving credit in the medical load, but at the end of the day, it was more important that plans receive some credit, whether the medical or non-medical load. And finally, if the state were to implement this approach, it would be important that they start simple, that they learn from their process, and that they adjust as needed. Plan leaders foresaw that implementing a rate adjustment approach in a state as large and diverse as California could be complicated. However, state-level acknowledgement of these investments is very important, so plan leaders were of the opinion that it's important not to get bogged down into the details at first, but instead to commit to implementing a rate adjustment and learn what works and what doesn't, refining this approach as time passes. One of the key components of the rate adjustment approach is that plans would have to invest a minimum amount into state-approved health-related initiatives. So we asked leaders what they thought about the specific investment component. When we asked plan leaders to tell us whether or not they would prefer a small or a large investment threshold, their opinions varied widely. Overall, they agreed that any rate adjustment proposal should include an investment threshold, but there was no consensus around what that threshold should be or what it should be based on. However, there was near universal consensus on what type of investments the state should approve for a rate adjustment. We spoke to a total of 26 plan leaders across the 14 plans that we interviewed, and all leaders, almost all leaders agreed that investments around housing availability, long-term care alternatives, behavioral health services and integration, and food security should qualify for a rate adjustment. As you are probably noting, these areas largely match up to what plans are already investing in. Plan leaders also emphasize the importance of maintaining flexibility in what they can invest while also maintaining some consistency. Plan leaders overall preferred that as many types of investments as possible be eligible for a rate adjustment, but they understood that the state is probably less likely to implement an approach that is as wide as that. So plan leaders, while preferring the state to approve an expansive list of investments, said that they were willing to move forward with a shorter list if it would be easier for the state to implement this approach. Like I mentioned, leaders prioritize receiving any credit for the investments they are already making. So they were also willing to forego some flexibility in the state for the sake of moving this approach forward. The last component I will cover today is the shared savings split between the plan and the state. Like I mentioned, if a plan were to make an investment that proved successful and generated savings, the idea is that the plans and the state would get to split the savings that emerged as a result of this investment. Nearly unanimously, plan leaders agreed that to start with, a 50-50 split of savings between the plan and the state seemed like a fair and tactful approach for incentivizing the state to implement this approach. However, plan leaders also thought that the split should shift over time in favor of the plans, given that savings are likely going to become more difficult to generate as time passes and as hopefully members' health outcomes improve and care utilization declines. So, like I've mentioned a couple times now, overall, our plan leaders made it pretty clear, in our conversations with them, that it's really most important that the state give them a signal that it supports investments that focus on social determinants of health. A rate adjustment approach is a potential policy change that would reduce some of the risk that plans are taking on when making these type of investments and would make them more sustainable. And it's a policy that many plans support, but it's not the only policy. There is strength in numbers, as I said before, so if this is an approach that Medi-Cal managed care plans do want to move forward, it will be important to define some shared expectations for a rate adjustment proposal through something like a shared policy platform. As you probably noted while I was describing our findings around this approach, there is still a lot of opportunity for consensus building and defining expectations among plans. If you're interested in learning more about what plan leaders have to say regarding a rate adjustment approach, our findings are detailed in the report pictured on this slide, which is available now at jsi.com/signal of support. And I believe CAP leadership also shared with you all when you received your invitation to this webinar. So now the moment that we have all been waiting for, I will open the floor up to questions. Like I mentioned, you have all been on mute. However, you do have the capacity to unmute yourself if you have any questions, or use the chat box feature available through WebEx, which is located usually on the bottom or the right side of your screen. Go ahead and type in any questions in there, and we have about 5 or so minutes for questions before we wrap up. So there is one question on the chat box currently. So I will read this aloud and respond. What was the foundation in LA you mentioned on opportunities for Medi-Cal plans when talking about evaluation? From Jessica. Jessica, thank you for this question. So I mentioned LA, I think once, which was when I was specifically talking about their investment in housing, and the foundation that they provided a grant to, the LA Care provided a grant to, is called Brilliant Corners. They are a nonprofit supportive housing organization, and they actually operate throughout the state, but have presence in LA County. So that was the foundation there. There is another question around the rate adjustment approach. So the question is if we have any sense whether the state/CHCS is considering this option. So that is a great question. The most honest answer I can give you right now is that the specific approach that I was describing and that we explored came from a report published by the California Healthcare Foundation, and the report covers a working group that included Medi-Cal leaders, and this work group was led by Manat and Optimus. And so the Medi-Cal leaders are definitely aware of the approach and proposal, but I have not necessarily heard whether the state is currently considering this as an option. My sense is that the field is becoming increasingly aware of it as an option, and the California Healthcare Foundation continues to explore this approach. And so it will be exciting to see how it develops. And as I mentioned, one of the key opportunities we identified for health plans is coming to a consensus around what they would want a rate adjustment approach to include. I think before the state starts considering any approach, they would want to see something that they know many people are behind. Thank you for that question. Any other questions? Feel free to unmute yourself as well if that's easier than the chat box. Hi, everyone. Sorry about that. Give me 1 second. I believe I pressed the end call feature. Can people hear me? If so, can someone type in the chat box? Oh, yes, I believe people can hear me. Great, thank you so much. Apologies for that quick mishap. So there was one more question around the differences, if there was any analysis of differences between local and commercial plan responses. So thank you for this question. We actually purposely did not analyze any differences between local and commercial plan responses. When we first started this work, we wanted to involve the plan associations and the plan leaders as much as possible and take their input into consideration. And some feedback we got early on was that plan leaders prefer that this analysis be done semi-anonymously. So, for example, the examples that I discussed that I went through today are examples that are publicly known, but otherwise, plan leaders are more willing to speak to us on the condition of anonymity. However, like I mentioned at the beginning of the presentation, most of our responses did come from local health plans. Our survey, I believe, featured responses from 6 commercial plans out of a total of 19 respondents, and our interviews included 4 commercial plans out of a total of 14 respondents. So by sheer numbers alone, this data does encapsulate what is going on, both commercial and local health plans, but a lot of the examples do come from local health plans. Thank you for that question. Any other questions? We have time for about 1 to 2 more questions. All right, so it does not appear that there are any other questions for the moment. However, if you have any additional questions, please feel free to contact me. My email is available on this slide. I am available at nicole_jerome@jsi.com. And I also wanted to note that both our reports will be available at jsi.com. Our report around the rate adjustment approach is already available at jsi.com/signal of support, and our more expansive report covering what I spent the majority of today discussing will be available very shortly, within the next month or so. We will make sure that it gets out to the associations and that it lands in your inboxes, hopefully. And so before I close, thank you so much to everyone for your time and your great questions today. We are very grateful for all of the time that plans gave us for this work. all of the hours plan leaders spent talking with us, and we are excited that we are able to start sharing it with all of you. So again, if there are any additional questions, please feel free to contact me. And with that, everyone else have a great rest of your day. Goodbye, everyone.